Welcome to this e-cancer discussion looking at EGFR Exon20 mutated non-small cell lung cancer and recent advances that have been presented this year at ASCO 2021 and implications for the treatment of our patients. My name is Dr. Mathew Krebs. I'm a medical oncologist at the Christie Hospital and University of Manchester, United Kingdom, and I work in early phase drug development with an interest in particular for lung cancer. I'm joined today by a great set of colleagues to discuss these recent data, and I'll just invite them to introduce themselves for the purpose of the meeting. So let me go around the room. Dr. Viteri.
Hi, thank you very much to the organizers for inviting me, and it's a pleasure to meet these colleagues to discuss about this fascinating topic. My name is Dr. Santiago Viteri. I am a medical oncologist devoted to lung cancer treatment and molecular oncology. I work in Barcelona at Instituto Oncológico Dr. Rosell, led by Rafael Rosell, a great pioneer in the investigation of EGFR mutations. And as I said, happy to be here with you.
Thank you. And Dr. Gadgeel.
Thank you very much, Dr. Krebs. Yes, I'm also very glad to be in this discussion. My name is Dr. Shirish Gadgeel. I'm a medical oncologist and chief of division of hematology oncology at Henry Ford Cancer Institute, Henry Ford Health System in Detroit, Michigan. Thank you.
And Dr. Cho.
Hi, everyone. I'm very glad to discuss about new development in EGFR Exon20 this year. I'm Byoung Chul Cho, lung medical oncologist, chief of Lung Cancer Center, Yonsei Cancer Center, South Korea.
So thank you. It's really great to have you all here for this discussion. I'm really looking forward to discussing these data. So I think it's exciting times for EGFR Exon20 insertion and management of these patients. There are a number of emerging exciting therapies coming through. I think perhaps one of the first things is we're beginning to learn a little bit around sort of natural history of these mutations, how the prognostic impact of having an EGFR Exon20 insertion compared with other EGFR mutations. And there have been a couple of real-world data studies presented at ASCO this year. And I'd perhaps just like to focus on those first of all, just to get a feel for what is the sort of standard management that's going on at the moment from those analyses and how that really compares with your own practice currently. So perhaps, Dr. Viteri, can we start maybe with the abstract that was presented from France around some real-world data of EGFR Exon20 insertion in the context of first-line treatment setting?
Yes, of course, whenever we face these driver mutations that we don't know very well yet, the first thing we need to do is to try to best characterize them, to know the population, what kind of patients, what is the real frequency at our settings, etc. No, so this is the main aim of this abstract, this effort from the French investigators. They analyze the data from a data platform that collects information, retrospective data from patients. That includes more than almost 15,000 non-small cell lung cancer patients with the treatment information, etc. So they interrogate the database and found EGFR mutated patients, and then in this group they detected those who had the exon 20 insertions. That we know that the exon 20 insertion is the third mutation in frequency. First of all, the frequent ones, the sensitive ones that we know, that exon 19 deletion, and then the point insertion in exon 21. The third mutation in frequency is the exon 20 insertions. It's very important to know that there are many types of exon 20 insertions, different variants. And this is more or less what we know from previous series, around 5% to 12% of EGFR patients. In fact, in this work, they found 61 patients, accounting for 3.9% And the characteristics of these patients, well, of course, the number of patients is small, but they found more female patients, more smoking or non-smoking status was even. And most of the patients were diagnosed with advanced disease. And the age was not so young as the typical EGFR mutations that we're familiar with. The treatments, when it regards to treatments, many patients, most of them were treated with platinum-based chemotherapy, some EGFR TKIs, the common, the first or second or even third generation EGFR TKIs were used, but the results were poor, which is something that we already know, no? With a short overall survival, and especially if we compare them with the EGFR sensitive mutations.
Yeah, so I think the sort of data are beginning to show that they perhaps behave similarly to a patient that doesn't have any sort of driver alteration, I guess. I mean, it's interesting that a certain proportion of patients were treated with the standard tyrosine kinase inhibitors. I wonder, Dr. Gadgeel, do you want to comment on that? I mean, why do you think that is? What would be your own practice for these patients?
Yeah, so I believe among community oncologists, the knowledge about exon 20 EGFR mutations has evolved. I suspect as initially there was so much attention to exon 19, and as Dr. Viteri mentioned, the point mutation in exon 21 and LET58R, which are highly sensitive to all the available EGFR TKIs, particularly to osimertinib. And so there are occasions, particularly in the past, when oncologists may not have appreciated that exon 20 EGFR mutations are a distinct population and are tumors that usually are not responsive to the currently available EGFR TKIs. And as was demonstrated in this database, that the duration of treatment was extremely short with these EGFR TKIs, almost as if they had no benefit, which is what is shown in preclinical studies and in the clinical database. And I think there's a much greater appreciation now with all the data that is emerging about exon 20, that when EGFR mutation is identified, that we understand what specific mutation exists in the patient's tumor. I also believe that there is a more practical aspect to why there is a greater recognition of exon 20. In the past, several institutions across all countries did point mutation analysis. So there would be specific mutation analysis for exon 19 and the point mutation exon 21. But as we have gone to multi-gene assessments and particularly to NGS testing, we are much more frequently identifying these exon 20 insertion mutations. And so all the more imperative that we are aware of these mutations and their unique sort of clinical course and their lack of responses to EGFR TKIs.
Yeah, I think that's a really great point. And there's differences also between the different panels that are used, right, as to how many of the exon 20 insertions are actually analyzed. And I think it is worth just highlighting there's one very specific exon 20 insertion, right, that is highly sensitive to standard EGFR TKIs. I think it's the A763, the 764 insertion, which accounts for just, I think, 4 to 5% of the exon 20 insertions overall. But aside from that, as you say, they're not responsive to standard TKIs. There was also a second study presented with some real-world data, this time looking at the use of amivantamab in the Christie study compared with data pulled from 3 US databases in terms of standard of care practice in the second-line setting. I wondered, Dr. Cho, if you might comment on that study for us and tell us some of the highlights and pros and cons of these analyses.
Okay, so this is a real-world data set. So they compared Christie's one data set who are previously treated with platinum-based chemotherapy, 81 patient population, with a pooled real-world data set of 125 patients. This is a retrospective analysis, and there is a several caveat because this is a retrospective analysis. But in this data set, the key message here is the patient with the EGFR exon 20 insertion has a poor prognosis in terms of progression-free survivor and overall survivor. So in the patient who were treated with amivantamab compared to pooled real-world data set showed longer progression-free survivor and overall survivor in this data set.
Yeah, and perhaps you can comment on why these sort of data are important to look at the real-world comparisons rather than randomized control trials.
Because EGFR exon 20 is account for only 10% of EGFR mutant, all EGFR mutant NSCLC. It's not that large patient population like common EGFR mutations. So it's very hard to conduct a large-scale randomized phase 3 study in a second-line setting. So I think given the recent approval of amivantamab in post-platinum setting, it's important to conduct efficacy of amivantamab in patient previously treated with combination chemotherapy with a real-world data set. So in this data set, it clearly suggests that amivantamab is effective treatment option after progression on platinum-based combination chemotherapy in EGFR exon 20 insertion positive advanced NSCLC.
Yeah.
Anyway, Dr. Krebs, I was just going to add just 2 points to the excellent points that Dr. Cho made. One is that this data was quite relevant since amivantamab has received recent approval in the US for patients with exon 20 insertion EGFR mutation positive non-small cell lung cancer. But it is specified in patients post-platinum-based chemotherapy. So this is a little bit unique in that several of our targeted agents have been approved irrespective of the line of therapy. And so this agent has been specifically approved only in patients who had received prior platinum therapy because that was the group of patients that were enrolled in Chrysalis. So it was important to define the outcomes of exon 20 insertion patients in the real world who had prior received platinum-based therapy. As was shown in the French data, this was more about patients that were identified, newly diagnosed, and then how did they have an outcome. And so to have specifically patients with second-line therapy was the sort of the unique characteristic of this abstract. And the other thing I would add is that this may become a way of, one way of documenting benefits of targeted agents in sort of groups of patients where that are quite uncommon, such as NTRK or others, because it is so challenging to do randomized studies. And so these real-world databases across the globe, not just in US, are going to become extremely relevant in terms of defining the efficacy of these new agents.
And one more comment for this abstract. If given the lack of effective treatment, particularly after progression in patient after progression on platinum-based chemotherapy, in the real-world setting, there were various different treatment strategy, including single-agent chemotherapy, immunotherapy, tyrosine kinase inhibitor, and other therapeutic option. And combined efficacy from these diverse treatment option, progression-free survival in the pooled real-world data was only 2.9 months. So given the recent approval of amivantamab and excellent efficacy data of these agents in post-platinum EGFR exon 20, these real-world data clearly suggest that amivantamab should be a standard of care in post-platinum EGFR exon 20 insertion NSCLC.
Yeah, and I think even despite the limitations of these real-world data analyses, they are important data, and I agree, Dr. Gadgeel, and it's quite refreshing that the regulatory authorities now are willing to look at and accept these data as an alternative to randomized control data, where it just simply isn't possible to obtain that for these rare populations. So I think, yeah, TREC is a great example of where we've seen that. Both amivantamab and some of the newer therapies, which have also been presented at ASCO this year, and we'll come on to just in a moment, tend to be in that post-platinum setting. I don't know if anyone wants to comment around whether we should be looking at these therapies in the first-line setting. I appreciate it tends to be the later stages we start and then bring it forward, but perhaps Dr. Viteri, do you want to comment?
Yes, if we think about what happened with common EGFR mutations, no, at the beginning we had the same dilemma. No, platinum-based chemotherapy has been our backbone and standard treatment for many kinds of patients during decades, and it's difficult to get rid of them. These drugs. I mean, we know that they are not specific. We know that they are not the solution of the disease, but we know that they are helpful. So we shouldn't easily just forgive them and run to the forget them and run to the new drug in the block, no? But the truth is that whenever we have been able to identify a driver mutation and we have been able to design a drug that specifically targets this driver, the results have been outstanding and very easily overcome the benefits of regular chemotherapy. If not only in the efficacy setting, also in the safety, no, or in the side effects that you usually are much better tolerated for patients. And if you ask patients, you know what will be the answer. Most of them prefer anything but chemotherapy, no? But the truth is that, for example, in the amivantamab example that we are discussing now, there is a clinical trial ongoing, is a Papillon, which is first-line exon 20 EGFR compares platinum-based chemotherapy plus against amivantamab plus chemotherapy, which is trying to determine if the addition of the two agents or the two approaches can be feasible for this kind of patients.
Yeah, I think that'd be a very important trial. So just on this theme then of sort of tolerability and thinking about some of the other agents coming through. So there's a few oral agents we've seen presented. So we've had mobocertinib and TAS-6417 and another compound as well presented, which you can come to. But I guess in terms of all these, and also throwing amivantamab into the mix, we have to weigh up how efficacious are these drugs, what are the tolerability profiles, etc. So just with all that in mind and thinking about how on earth we're going to navigate exon 20 emerging therapies in years to come if they're all approved, perhaps we can focus for a moment on some of these data. So I wonder, Dr. Gadgeel, do you want to talk us through the mobocertinib data that was presented in platinum pre-treated patients and the EXCLAIM expansion cohort?
Yes, so in this particular trial, we have seen the data from mobocertinib in the past, but this was sort of an update in combining two specific populations from the phase 1/2 trial of mobocertinib. There were 114 patients in the prior platinum cohort, and then there was a more broader cohort called the EXCLAIM cohort that about 96 patients. The update showed both responses as assessed by investigators as well as independent review. And the independent review response rates were somewhat more modest at about 25 to 28%, whereas the investigators assessed responses were in the range of 32 to 35%. The median progression-free survival holds up at about 7.3 months, which is what was reported in prior presentations of this database. The median overall survival was 24 months in this patient population. There was efficacy observed with this drug across all exon 20 insertions. So benefit was not restricted to specific mutations. I think the limitation continues to be the toxicity that is observed with many of these agents. The primary limitation of many of these EGFR TKIs is that the difference that we see in inhibition, in inhibiting mutant EGFR with regards to exon 19 and exon 21 L858R mutation, as opposed to wild type EGFR inhibition, is somewhat much more narrow when it comes to exon 20, in that the doses required to inhibit exon 20 also land up inhibiting wild type EGFR to some extent. And therefore, that lack of selectivity leads to toxicities that I suspect limit the tolerability of these agents, particularly in terms of diarrhea, stomatitis, and rash. One other aspect observed in this database was CNS was identified as a common site of progressive disease in this patient population. So unlike the efficacy of osimertinib against CNS metastases in patients with sensitive mutations, there may be some limitation in terms of CNS efficacy with a drug like mobocertinib, whether that is because of lack of ability of the drug to cross the blood-brain barrier, or it is just that the toxicities limit the ability to dose the drug at an effective dose, is unclear. The dose reduction rate was not very high, 20 to 25%, and the dose discontinuation rate due to AE was not very high. Nonetheless, I do believe that the toxicities limit the ability to tolerate these drugs.
Yeah, all really fantastic points. And I agree about the CNS penetration. There does seem to be a difference compared with the standard TKIs that we've seen. Let's just talk about some of the other data that were presented as well. So theoretically, a more selective inhibitor is DZD9008. Perhaps, Dr. Cho, do you want to tell us the data from that study? It's relatively early days.
Okay, so DGD is also a potent selective EGFR exon 20 insertion EGFR inhibitor showing potent activity in vitro model and in vivo models. So in phase 1 study, they had a dose escalation and dose expansion cohort, and they escalated dose from 50 milligram QD to 400 milligram QD. And in dose expansion cohort, they had a 2 cohort of 300 milligram QD and 200 milligram QD. So the demographic of the patient was typical of EGFR exon 20 insertion in general, and had a safety set of slightly over 100 patient, and efficacy set of 56 patient cohort. DGD had a generally well tolerated safety issues, and had a grade 3 toxicity of 6.3% in 200 milligram QD, and about 30% of grade 3 or higher worse adverse event in 300 milligram QD dose, and suggesting that severe toxicity was correlated with the dose. Most common adverse event, as expected, were diarrhea, rash, and several GI toxicity. And vast majority of toxicity were grade 1 or 2, and grade 3 toxicity was not common with DGD compound. Anti-tumor activity of DGD compound showed around of 40% in all 53 efficacy set, and efficacy was shown regardless of EGFR exon 20 insertion genotype, and showed about 90% disease control rate. Response rate was shown across all dose level, but confirmed objective response rate was reported to about 45% in 200 milligram QD and about 40% in 100 milligram QD dose. The durational response and median progression-free survival is still immature, and we need to further follow up with this compound.
That's great, thank you. And just before we open it up to a bit further discussion, I wonder if Dr. Viteri, you could tell us a little bit around the TAS-6417 compound as well.
Well, as we discussed, there are several compounds targeting the EGFR Exon20 insertions, and this compound that formerly was known CLN-081 is an oral EGFR TKI with broad activity against all kinds of mutations, including the exon 20 insertion. And it is supposed to have an attenuated activity against the wild-type EGFR compared to the exon 20 insertion, making this potentially with best safety profile, avoiding some of the side effects that we think that are related with the wild-type inhibition. And allowing us probably to use higher doses. No, these are at ASCO they were presented the interim results of multicenter phase 1 and 2 clinical trial, particularly in advanced EGFR Exon 20 patients. By the time of the communication of the results, 37 patients have been treated. So most of them have received previous lines of therapy. They tested doses of 30 milligrams up to 150 milligrams twice a day. And the most common side effects were, as expected, rash and diarrhea, and other typical side effects of EGFR inhibition as stomatitis or dry skin. Grade 3 were not so common, 3% of diarrhea, 5% of anemia. So it seems that the drug was quite tolerated at this point. And regarding the efficacy, what we can see is that among the 25 patients that were evaluable, 10 had partial responses, meaning 40%, and 14 had a stable disease, accounting for almost 96% of disease control rate, which is quite promising.
So thank you. So some really interesting compounds coming through, I think. And amivantamab data were presented at World Lung, I think, this year with a response rate of around about 40%, relatively low grade 3 toxicity, and a PFS of just over 8 months, I think. But obviously it's an IV administration rather than an oral administration. So perhaps just to open this out, what are your thoughts around this emerging landscape and sort of where next? And I guess amivantamab is already FDA approved, but interested for your thoughts about where things are going here.
Let's start off with talking about amivantamab, which is approved, as you mentioned, a 40% response rate, and also what appears to be a progression-free survival, with a note of caution that this is a cross-trial comparison of that appears a tiny bit better than some of the PFS we have observed with TKIs exceeding 8 months. Amivantamab does have a unique adverse effect of infusion reaction, which almost appears to be universal with the first dose, and one needs to be mindful of that. But the good news is that it doesn't appear to be the case after the second dose, but one needs to be mindful about this infusion reaction and measures to mitigate that. The other comment I would make is I really believe now we have several TKIs that are very efficacious. However, I do have a question about their ability to selectively inhibit exon 20 as opposed to wild type EGFR. And the consistent theme appears to be that we see a response rate, at least in the initial results, of 35 to 40%. But as we expand the cohort or increase the number of patients that are enrolled, particularly at the phase 2 dose or the recommended phase 2 dose, we are seeing that the efficacy drops down to maybe less than 30%. And I suspect that that is primarily because as you enroll more patients, particularly at the recommended phase 2 dose, we are seeing a little more wild type EGFR activity resulting in toxicities that are somewhat challenging to manage. And I think that's a bigger limiting factor. And at least in the data sets that I've seen, including of DZD9008 and the CLN081 data, it looks comparable to the initial results that were reported with mobocertinib and poziotinib. It remains to be seen as we enroll more patients whether we will see that selectivity. And I think that that is emerging as a challenging factor in developing particularly TKIs for these group of patients. The hope is with DZD9008 in particular that there would be selectivity. But again, the data to me seems not too dissimilar from the initial reports of poziotinib and mobocertinib. And as more data came out with those two drugs, the efficacy did appear a little more modest than the initial report. So let's see what happens with DZD9008.
Yeah, I agree. And any comments from Dr. Viteri or Dr. Cho?
So I totally agree. As Dr. Gadgeel already mentioned, for example, DZD9008, PK data suggests that the higher dose may be more beneficial in covering phospho-EGFR of cells carrying EGFR exon 20 insertion. But in the clinical setting, higher dose produce a higher incidence of grade 3 or worse EGFR inhibition-related toxicities such as skin rash and diarrhea. So they could not go up the higher dose. So they selected a 200 milligram QD and 300 milligram QD as a potential recommended phase 2 dose. So I think the tolerability is a big issue with the small molecule TKIs with DGD and CLN081 compound too. But interestingly enough, in a one or two patient in each data set, these small molecule had a response after progression on amivantamab, suggesting that these two agents may not have overlapping resistance mechanism. So at the end of the day, if we have several more TKIs in our clinic, we may face a issue of sequencing of these agents for our patients.
Yeah, indeed.
Yes, I totally agree with Dr. Cho. I think that the good news is to have different drugs with different mechanisms of action. We don't know how important could be that amivantamab also inhibits MET. We know this is a common resistant mechanism in EGFR mutations, or at least in common ones. And the sequence can be interesting, and also the potential of the combination, no? That also it is also being tested in ongoing trials.
Yeah. So on that note, actually, just in the last couple of minutes, there are a couple of trial in progress reports as well. One was around a subcutaneous administration of amivantamab rather than IV, and one was a combination with lazertinib in various different settings. I wonder, perhaps, would you like to comment, Dr. Viteri, on those two abstracts as well?
Well, yes. In particularly with amivantamab, one of the challenges is that the administration is intravenous. as Dr. Gadgeel mentioned, and the infusion reaction is one particular toxicity that is very specific to this drug, and it requires some training to deal with it. I mean, because it can be somehow scary for your patient and the doctors that are on the floor at that moment, but it's usually manageable, and it only occurs with the first dose. And the other thing is that at least with the design trials, the administration is weekly during the first month, and then every 2 weeks, which is a little more uncomfortable and problematic for the organization of our hospitals compared to orally taken drugs. So the intention to test the subcutaneous administration could help to resolving some of these problems. We don't know if the infusion reactions will be lower. It's expected maybe, but also the time of administration and the to make it easier for patients and teams to administer the drug, and that's very appealing for the near future. Also, I think that there is the possibility that new schedules of treatment would be tested with the drug, not every week
Yeah.
or every 2 weeks.
Yeah.
And also, as we were speaking before, the combination with EGFR TKIs, no? EGFR TKIs have different mechanism of action, and you could potentially block the EGFR receptor in the extracellular domain with the antibody, and in the tyrosine kinase domain, enhancing the efficacy. The problem here could be the safety or the feasibility of this combination. No, we know that some of the newer EGFR TKIs have some problems, because if we need to target the exon 20, we need a potency that is difficult to manage, and also we don't have to forget that we are also inhibiting MET. So the overlapping of the MET toxicities plus the EGFR toxicities can be a problem, and we are eager to know the results of these lazertinib amivantamab combinations.
Okay, thank you. I think we could continue to discuss this for quite some time, but I think we run out of time. But this has been a really great discussion. I'd just like to give great thanks to all three of you, Dr. Viteri, Dr. Gadgeel, and Dr. Cho. Thank you for your time. Thank you for your interaction, and thank you also to eCancer. Thank you. Bye-bye.